دكتور ابراهيم لا تكمل المحاضره. الدكتور ابراهيم الالي will present his presentation about MRI pituitary. This is very important. Dr. Ibrahim specialized in endocrine imaging. He gave us thyroid imaging in the previous presentation. It is very helpful to everyone. And pituitary MRI and CT adrenal is very, very helpful in the exam. So go on, Dr. Ibrahim.
Inshallah ta'ala. In our presentation here, we will talk about basics of MRI imaging. Then we will talk about normal anatomy of the pituitary area. Then we will talk how to differentiate between sellar and suprasellar lesions. Then we will talk about suprasellar lesions and sellar lesions. First, how to differentiate between T1 weighted images and T2 weighted images. T1 weighted images is just like the normal anatomy. The CSF seem to be dark on the low intensity. The gray matter will be dark. And like here, this is the gray matter, and the white matter will be bright on T1 weighted image. But while in T2 weighted image, the whole situation inverted, so the CSF become bright, the white matter become darker, like here, and the gray matter become brighter. How to differentiate also between pre and post contrast images. In most cases, it is easy to know that this image with or without contrast. Here in the A and D image, we see here it is a coronal images, and this is a sagittal image. We can look to the nasal concha, see that its intensity is just like the gray matter here. But when we contrast the enhancing material, it is become brighter than the gray matter, and we see here that the folx cerebri become brighter, and the dura mater around the brain is become brighter. So this is also the nasal concha here become brighter than the gray matter. Also, in most cases, we can see some vessels. We can see some vessels to become brighter after enhancement. The normal pituitary gland, the about 8 millimeter in size. It become increased in females and adolescents, and after immediately after pregnancy, and in primary hypothyroidism. The pituitary stalk normal size is about 4 millimeters. This is a pre-contrast and post-contrast coronal images for a normal pituitary. This is the third ventricle here, and this is the optic chiasm. This is the pituitary stalk, and this is the anterior pituitary. These dark circles are the internal carotid artery, two sections in the internal carotid artery. The most important organ near the pituitary gland is the cavernous sinus system, which contains some vital organs like the carotid artery and the cranial nerves, third, fourth, sixth, and two branches of that trigeminal nerve. The cavernous sinus should be focused on in pituitary imaging, especially when there is a tumor in the pituitary gland, because the invasion of the cavernous sinus will make the surgery not cure. We can expect that the cavernous sinus is invaded by the pituitary tumor just when we see the pituitary tumor cells lateral to the carotid artery, like if we see here cells of the pituitary tumor, so that that is a significant sign that the cavernous sinus is invaded. Or we can use this technique. We draw a theoretic line between the on the median line between the carotid artery. If any pituitary tumor just through this line, that means that the cavernous sinus is invaded by more than 50%. This is a sagittal image, pre and post contrast in a normal pituitary area. We see here that the third ventricle here. We see here this is the optic chiasm, and this is the pituitary stalk, and this is the anterior pituitary. And if we focused here, if the bright area here, this is the posterior pituitary, and we see that all the pituitary glands become bright after enhancement, so we cannot differentiate between anterior and posterior pituitary after enhancement. Here we can see the sphenoid sinus, which is the entrance of the transsphenoid surgery. And this is the mammillary body. This organ is important because the area between the mammillary body and the pituitary stalk called tuber cinereum, and it is a common site for the most CNS tumor causing central precocious puberty, which is the hamartoma. The hamartoma site is here in this tuber cinereum. Now, the suprasellar lesions, if we divided it between adults and children, the most common cause of suprasellar lesions in adults is extension of pituitary adenoma, suprasellar, then the suprasellar meningioma and aneurysms, while in children, the most common suprasellar lesion is the craniopharyngioma, then the hypothalamic glioma and aneurysms. In the coming slides, the presentation will be case-based. First case, a 30-year-old man came to the endocrine clinic with coarse features developed over years, hypertension, type 2 diabetes mellitus, elevated insulin-like growth factor 1, and unsuppressed growth hormone after 75-gram administration of glucose. You asked for pituitary imaging, and you see this. What we see here, if someone could comment. Do you hear me?
Yes, can hear you with the image.
Yes. Yes, this is the coronal image. We can see.
Dr. Ibrahim, we want interactive discussion to.
Yes. Okay. Some of colleagues comment, please.
This is Supra.
Okay.
Yes, Dr. Hassan. Okay. Yes, anyone can comment?
Yes, it's me, Dr. Nashad. This is suprasellar extension. It is to the pituitary tumor with compression to the pituitary stalk. The optic chiasm, sorry.
Optic chiasm
compression.
Yes, we see here sellar or suprasellar lesion that compress the optic chiasm. This is the most important thing. If we see all images here, this here in the coronal images, this is sellar and suprasellar. This is a good point to discuss. How to know that this lesion is sellar or suprasellar? First, we look to the sella torsica here. If it is expanded, then mostly that this lesion originated from the sella and expanded into suprasella. See here that this lesion invaded the sphenoid sinus, so it is originated from the sella and expanded here into the suprasella and compressed between the optic chiasm. So we see here the optic chiasm is compressed, and we see here a pituitary tumor cells lateral to the carotid artery. So yes, the cavernous sinus is invaded, and so this is here the frontal sinus expanded, and this is one sign of acromegaly. And sometimes we can see the occipital scheme folds here also magnified in this acromegaly. The second case, we were asked to see a 48-year-old lady in the neurosurgery department. The patient had headache and vision abnormality. Hormonal study was normal. Electrolyte and osmolality were normal. You examined MRI pics and found this. Someone comments, please.
Hello?
Yes, doctor.
Dr. Ibrahim.
Yes, doctor, I'm hearing you.
Meningioma, I think.
Yes, of course.
This is hemorrhage into pituitary.
No,
Okay.
no, not that.
This is, first of all, this we should know that this is a coronal images with contrast material. Okay, we see here two tumors, one on the above, and one here in the on the Sellar area. Okay, this is a homogeneous enhancement of the tumor, and the Sella is not expanded. Okay, so it is a suprasellar lesion invaded the Sella. Okay, and we see here this sign. This is important sign here. The dura just close to the tumor is highly enhancing the gadolinium. This is the dorsal tail. It is a pathognomic sign for what? For meningioma. Here also we see this is the Sella not expanded, and a suprasellar lesion with a dorsal tail with a homogeneous enhancement, so it is a meningioma. Here we see also the pituitary gland. This thin line here, pituitary gland. This is the meningioma, and there is important something to note that the meningioma different from the pituitary tumors that it constrict the vessels. So this is the carotid artery stenoted, while when we saw that acromegalic patient, like here, you see this, it is not stenotic. Okay, this is the compressed carotid artery, and this is the dorsal tail, and this is the anterior pituitary. The meningioma enhancement, the enhancement and thickening of the adjacent dura is referred to as dorsal tail, and is a characteristic for an underlying meningioma. As I mentioned before, the enhancement is homogeneous. Now, the third case, you were asked to see an 8-year-old boy in the neurosurgery unit. Symptoms and signs of polyuria, headache, and elevated intracranial pressure. Laboratory findings of central diabetes insipidus and growth hormone deficiency. You found the following lesion on MRI. What do you think?
This craniopharyngioma with cystic lesion.
Yes, we see here that this is first, as usual, this is coronal images. This is T2 weighted images. We can see here a large cystic component here, and suprasellar, just suprasellar, we see this solid component. This is the most characteristic sign for craniopharyngioma. This is also coronal images, pre and post contrast. This is pre-contrast images, and this is post-contrast images. This is the cystic component, okay, and this is the solid component. We see that post-contrast, the cystic, the solid component enhance the gadolinium, okay. This is cystic and solid components, and also this is sagittal and axial images for the same patient. We see here that the sella is not expanded. The craniopharyngioma may become at any age, 50% of cases in childhood less than 16 years. It is a benign, but with a high recurrence and increased mortality. The cystic component is almost always present, but solid component may not be common or may not be always present. The solid component, as we see also in this patient here, pre-contrast, low intensity, but it has a high intensity post-contrast. We see here, this is the pituitary gland in this patient. The fourth case, a 50-year-old boy came to the endocrinology clinic with a short stature. On examination, you find these lesions. What do you think?
Neurofibromatosis.
Neurofibromatosis.
Yes, this is the cafe au lait lesions.
And leash nodules.
And this is leash nodules in the iris. The patient was below 2.5 standard deviations, the expected height and bone age. He was diagnosed with growth hormone deficiency and hypogonadotrophic hypogonadism. After finishing his study, the boy was diagnosed with a neurofibromatosis type 1. You asked for catecholamines screening. It was negative, and for pituitary MRI, and we see these images. Okay. All these images is coronal images. We see here, this is the pituitary gland, and this low intensity lesion, suprasellar. Okay, this is type 1. This is T1 weighted images without contrast, T1 weighted images with contrast. The enhancement is inhomogeneous. Okay, and this is the T2 weighted images. The lesion is high intensity in the T2 weighted images. This is the anterior pituitary. The glioma is the diagnosis for this case. The glioma, it appear low signal in T1 and high signal in T2. It may become homogeneous, or as our case, this heterogeneous enhancement. It is infiltrative disease, but in a neurofibromatosis type 1, it seems to be indolent, and this tumor is solid, no cystic components. The fifth case, a 7-year-old boy came to the endocrinology clinic by his parents, who were worried about increasing aggressive behavior and enlarged genitalia. During workup, the patient was Tanner 3 stage impropriety, increased bone age by 2.5 standard deviations. Laboratory study confirmed the diagnosis of central precocious puberty. The MRI image showed these findings. What do you think?
Radke cyst?
No, Radke cyst don't came like this.
This is.
As always, I like to make some hints. This is the optic chiasm, to know what we are looking for. This is the pituitary stalk. Okay. This is the anterior pituitary. And we have this lesion.
Yeah, this is cystic lesion. Arachnoid cyst, yeah. Arachnoid cyst.
This is the arachnoid cyst, which is a common etiology of
yes. Yeah.
Another the common etiology for central precocious puberty, actually it is the most common CNS tumor. It is Hamartoma. As I mentioned before, in the tuber cinereum area, which is between the pituitary stalk and the mammillary body, we see here this lesion, benign, and doesn't enhance after gadolinium enhancement. You see this? It is not enhancing. The pituitary stalk and the pituitary gland is untouched, and this is the lesion here, unenhancing after gadolinium. Rathke-Clift cyst. It is a recurrent question in the exam actually. We see it cystic component totally, no solid component, no calcifications. If this cyst enhance the gadolinium, the enhancement will be peripheral, just in this peripheral enhancement. And the T1, just like CSF, and the T2 also just like CSF, and always it comes in the median line in the pituitary or slightly above the pituitary. In this case, we see here the pituitary gland enlarged, but after gadolinium infusion, we see that there is a cyst here. So it is Rathke-Clift cyst. The epidermoid cyst, like Rathke-Clift cyst, but the fluid component, not just like the CSF, it is not clear like Rathke. The sebum we can see here, and we can see here. It is not just CSF like Rathke-Clift. But the location, it's almost the same, yeah. Above the pituitary gland on the median line. The sixth case, a 37-year-old lady referred to the endocrine clinic for amenorrhea evaluation. She had galactorrhea. Prolactin was 200 nanogram per milliliter. You asked for pituitary MRI and found this. This is a pre-contrast image and post-contrast image. What do you see? It seems like it is normal here, and post contrast is also seems to be normal. Seem to be normal. Pre and post contrast, yes. Also, this is the pre contrast imaging. Also seem to be normal. Then what is the cause of hyperprolactinemia? And just like these cases, we should know something important about the dynamic imaging. The dynamic imaging, I can see it is dependent on the fact that the pituitary pituitary adenomas delay the enhancement after the normal pituitary tissue. So we should make an imaging continuous image to catch the adenoma when it is not enhancing, just like the normal pituitary. Okay. We see here, if this is the post contrast image, it looks to be normal. Yeah, but if we early after infusion see this image, we can see the microadenoma in the left side. Okay. And also there it is, the adenoma we are looking for. So it is important in Cushing, especially under the microprolactinoma, when we suspect of microprolactinomas, to order the radiologist to make dynamic imaging. Yes. In the seventh case, a 23-year-old girl was asking for about increasing hair growth, no visual symptoms, no galactorrhea, no obesity. During workup, you found that prolactin is 97 to 170 nanogram per milliliter. You sent for pituitary MRI, and you see this. I want a description for this lesion, please.
This is pituitary macroadenoma extending to the internal carotid.
Okay, we can see that this is a coronal image without contrast material. Okay, this is the pituitary expanded with this high intensity lesion within it. and this is a bit deviated pituitary stalk. Okay.
Yes.
Yes.
This is the pituitary stalk, which is pointed by the yellow arrow. And this lesion is in the T1 weighted images bright. Also in the T2 weighted images, it is bright, and its intensity more than the CSF. So the most point here that it is a blood. This is a hemorrhage. Okay. So what this hemorrhage or this pituitary stalk deviation caused the prolactin, or it is a prolactinoma but hemorrhagic. We put this patient on a treatment of cabergoline without any surgical treatment, and after 3 months of treatment, we see that this adenoma becomes distant. Okay, shrinked, yes, and this is the pituitary stalk became normal, and the anterior pituitary became normal in size. So that was a prolactinoma, hemorrhagic prolactinoma. Okay. In the 8th case, you examined a 53-year-old patient in the neurology unit admitted for subarachnoid hemorrhage and a cellular mass on CT. On examination, visual abnormality, laboratory study showed that prolactin is 1,700 nanogram per milliliter. You asked for performing a pituitary MRI. You see this lesion. What do you think? When describing a picture, I always we should know what is the time, what is the weighted images, and what is the coronal, sagittal, or axial. Okay, so this is
this is the coronal and T2 weighted.
Pituitary invasion to the sphenoid sinus.
Yes, exactly. This lesion on the T2 weighted images here show us the pituitary lesion expanded to the sphenoid sinus with this high number of prolactin, so it is prolactinoma actually. And we see here in this coronal images that lesion here, and we see it in the sagittal images. Okay, this is its borders, and that is the invasion of the sphenoidal sinus. And these high intensity signals here, the subarachnoid hemorrhage. In the 9th case, a 22-year-old woman came to the neurologist to be evaluated for chronic headache and visual disturbance. A cellular and was found on the MRI. We see here. This is not enhancing lesion, or not with gadolinium. It is a cellular mass expanded suprasellar. The laboratory evaluation showed panhypopituitarism, but normal urine exertion. Surgery done without a cure. Hormonal replacement had started, and patient started radiotherapy for non-functioning pituitary tumor. There is an important point here that we see that striction here. In the within the yellow arrows, that means the tumor originated from the Sella and restricted within the fragment Sella and non-functioning pituitary adenoma originated from the Sella and expanded suprasellar, and this is there is important way that this cystic changes. Okay, we see here that the Sella is expanded, so it is originated primarily from the cellular lesion. In the 9th case, a 50-year-old woman was diagnosed with prolactinoma, prolactinoma, and treated with cabergoline 0.5 milligram twice weekly for 2 years. Now he came for re-evaluation in endocrine clinic. Prolactin was normal. Other hormones screening is also normal. We requested for a new MRI to the pituitary and found this. What we see here.
Empty Sella.
This is a pituitary stalk. This is the optic chiasm, and this is the anterior pituitary. And this
Empty
is
Sella.
yes,
Mش
yes,
in between.
exactly. It is empty Sella after treatment. This is the same images for the patient. This is a pre-contrast image, and this is the post-contrast image. We see here that the pituitary stalk enhancing, and this is the remained pituitary gland, and this is a CSF here. Also for the same patient, just like this T2 weighted images and this T1 post-contrast. This is the anterior pituitary. So it is empty Sella. It is maybe primarily just congenital diaphragmatic defect or secondary after either surgery, pharmacotherapy, or radiotherapy, or pituitary infarction. The majority of patients have normal pituitary function. Hypopituitarism is found in less than 10% of cases. Pituitary stalk terminates into an empty Sella, and only a small amount of pituitary tissue is identifiable. In empty Sella cases, the pituitary gland height is less than 2 millimeters. This is another case of pituitary empty Sella, actually. There is also another hint to know if this is really empty Sella. We draw a line just above the carotid arteries. If the pituitary stalk just reaches this line, so it is empty Sella, like in this here. Okay. This is also empty Sella, total empty Sella. We see that line and where the pituitary stalk ends. Okay. This case, you were asked to see a 20-year-old girl who was admitted to the hematology unit for anemia. The patient had amenorrhea since 5 months and recurrent episodes of hypocalcemia. On laboratory evaluation, she was found to have hypogonadotropic hypogonadism, low prolactin, and growth hormone, but normal cortisol and thyroid function, and hypoparathyroidism. On hematology, she had a ferritin more than 2,000 nanogram per milliliter. So it is hemochromatosis.
Hemochromatosis, filtratus.
Yes, exactly. The pathognomic sign for hemochromatosis in pituitary MRI, it is the blackness of the anterior pituitary, especially in the T2 weighted image. But in these T1 images, we see that the pituitary gland is all here. This is for hemochromatosis.
Again, Dr. Ibrahim.
This case, 65. What?
Again, the previous one.
This hemochromatosis, you mean?
Yeah.
Yes.
Yes. In hemochromatosis, you see that the previous image, when we image sagittal image, we see the anterior pituitary and the posterior pituitary. True?
Yeah.
Yeah. Here, there is no anterior pituitary, just a black area, and just after it, we see the bright area here, which is the posterior pituitary. This is because the iron accumulation in the anterior pituitary. It seems a low intensity. This is the most radiologic sign to diagnose hemochromatosis, the absence of the signal of the anterior pituitary. Okay?
Okay.
Good. A 65-year-old man was admitted to the endocrine wards for evaluation for polyuria and polydipsia. he was a smoker, non-alcoholic, no previous known disorders. You performed a deprivation test and the patient had central diabetes insipidus. You found this on MRI. What we see here. This is sagittal images. Okay, we see the pituitary gland enlarged. The pituitary stalk here is also enlarged, and we see here a lesion in the hypothalamic area and just above it. This is a pituitary and pituitary stalk and the anterior pituitary metastasis. Okay. We should, in this, just in like these cases, we should combine the clinical case with the radiology case. If we see just radiology, just like this, it has a differential diagnosis. It may be histoplasmosis, it may be carcinoid, it may be metastasis, a lot of diagnosis. But when we see here that the patient had that the patient is a smoker, 65-year-old. This patient at last was diagnosed with lung small cell carcinoma. Yes. This is the coronal image here. We see that the optic chiasm also invaded with metastasis, and this is all enlarged, the anterior and pituitary stalk. Okay. The last case here, a 7-year-old boy was being evaluated for short stature. Routine laboratory was normal. Low IGF-1 provoked growth hormone was low. He was found to have secondary hypothyroidism and secondary adrenal insufficiency. This was the pituitary imaging. We see that the brightest spot is just in the pituitary, in the optic chiasm. We see here, this is the posterior pituitary ectopic here, and no pituitary, the absence of pituitary stalk. Okay, absence of pituitary stalk and the ectopic posterior pituitary. These findings, radiologic findings with the hormonal study diagnosed the pituitary stalk interruption syndrome. It is an extremely rare disorder, but I like it to put it just for informations. Okay.
Okay.
In the coming slides, I will give some questions from Dr. Khaled Banks. First, we talk about this question. The imaging of pituitary in the exam, either it is a helpful image with the question, or it is the core of the question about the diagnosis from the image. Okay. This is a 65-year-old man presented to the accident and emergency unit with sudden onset headache, nausea, and vomiting. On examination, he was drowsy with feature of third and fourth and fifth cranial nerve palsy. An urgent magnetic MRI brain was. What do you think about this image?
Pituitary apoplexy.
Good.
Yes, we see here a
Hemorrhage.
coronal image and enlarged the pituitary gland and high signal within it. It is a blood, and with this clinical case, it is hemorrhage. All of the following are indications for urgent neurosurgery, neurosurgical intervention in a patient with pituitary apoplexy, except deteriorating level of consciousness, ocular varices, severe and persistent visual field defect, severely reduced visual acuity, worsening visual field defect.
B. This is
what do you think?
B.
Yes, yes.
B.
Yes. All the other options is urgent surgery needs. Another question, a 75-year-old retired army man was referred to the endocrine clinic with symptoms including recurrent headaches, lethargy, and malaise. His general physical and systemic examination was unremarkable. Investigations, free T4 low, TSH low normal, central hypothyroidism, FSH and LH low,
Low.
testosterone low normal, prolactin is slightly elevated, 9 AM, cortisol 380 normal, MRI of pituitary was taken. We see this. What do you think?
In a large invasive tumor.
Yes, it is invasive tumor cause hypogonadotropic hypogonadism and hypoparathyroidism and non-secreting, so it is non-functioning pituitary tumor. Okay. Which one of the following is a definitive indication for elective surgery in a patient with non-functioning pituitary adenoma? Abnormal short synectin test results, optic chiasm compression, recurrent headaches, secondary hypothyroidism, tumor size.
Of the chaos conversion.
Of the chiasm.
Yes, exactly. Another question here. This is the MRI scan of a 22-year-old female who presented with a 6-month history of secondary amenorrhea. She is otherwise well, and there are no abnormalities on physical examination. From the history and MRI appearance, what is the most likely diagnosis? Acromegaly?
Microadenoma.
Yes, yes, it is microadenoma.
C.
Here it is, yes. Microprolactinometry. A 37-year-old woman with a 6-month history of tiredness and lethargy is admitted as an emergency, complaining of a severe retroorbital headache and visual disturbance. On examination, she has a left third nerve palsy. The findings of an urgent MRI scan are shown in the image. What do you think? Subarachnoid hemorrhage due to a posterior communicating artery aneurysm, or hemorrhage into a pituitary macroadenoma, or lymphocytic hypophysitis with suprasellar extension, or hemorrhage.
Lymphocytic hypophysitis with suprasellar.
Okay, how we differentiate lymphocytic hypophysitis with other lesions?
Diffuse enhancement.
I forgot to put a slide about lymphocytic hypophysitis. It is radiologically we see that the pituitary stalk is enlarged, and the just like the image of the metastasis. Okay, but when we enhance, we give gadolinium, it gives us a homogeneous enhancement for the anterior pituitary and for the pituitary stalk. The enhancement is homogeneous for all of it. It is just like tumors, but with the pituitary stalk widening, give us a hint with a clinical history. When we see a woman after birth with with autoimmune disorder with her or with her family, we will think about lymphocytic cystitis. This image, it is a coronal image without gadolinium enhancement. This is the good point we should based on. There is no gadolinium in this image, so it is not a lymphocytic hypophysitis. And this clinical scenario, it is not fit for the lymphocytic hypophysitis. Okay, so this we see here that the the pituitary gland enlarged, and we see a hemorrhage inside it. Okay, so it is hemorrhage into a pituitary macroadenoma.
Yes.
A 19-year-old student present to the endocrine clinic for review. He is concerned as over the past few months he has suffered from a progressive loss of interest in sexual intercourse and now has problems maintaining an erection. This has led to a breakup of a long-term relationship. Examination reveals blood pressure normal, pulse normal, and regular. There is no post-oral drop in blood pressure. Chest is clear, abdomen is soft and non-tender, and his BMI is normal. The neurological symptoms is normal. System is normal, apart from some evidence of temporal vision field loss. Investigations: hemoglobin is normal, white blood cells normal, platelets normal, sodium and potassium is normal, creatinine also normal, prolactin 700 to
High.
20 high. It is high. A cross-sectional MRI show us this lesion. What do you think? This lesion here.
Yes, cystic lesion.
Yes, this is the most important one. It is a cystic lesion, just like the CSF, within the pituitary gland. So what is it? Which of the following is most likely diagnosis? Meningioma, pituitary apoplexy, pituitary macroadenoma, pituitary
Thoracic,
microadenoma,
thoracic,
Rathke cleft cyst. Yes, it is
thoracic cleft.
Rathke cleft cyst. A 60-year-old man present with a several week history of polyuria and polydipsia. He reports no headache, but he does have double vision. He previously smoked 20 cigarettes per day for 30 years, but stopped 3 years ago. He has no notable medical history and take no medication. On physical examination, he appears thin and pale. His skin is dry. His height is 175 centimeters. BMI normal. His blood pressure normal, and resting pulse is low, 52. Examination of his cranial nerve reveal right sixth nerve palsy. Water deprivation test confirm central diabetes insipidus. I think it is just like the case I posted before. We see here just the same images, almost same it. Okay. This is a large pituitary gland and pituitary stalk.
Metastasis.
Which of the following is most likely cause of pituitary pathology in this patient? Pituitary macroadenoma, craniopharyngioma, meningioma, pituitary metastasis, or Rathke cleft cyst?
D. Pituitary
Yes,
metastasis.
it is pituitary metastasis. A 50-year-old man presented with disturbance in vision. On examination, there was a symmetrical bitemporal hemanopia affecting the upper quadrants of the visual fields. There was no ptosis and ocular movements were full. He also had partial hypopituitarism. Investigation showed this image. Comment, please.
Meningioma. This is suprasellar mass with expansion to the Sella.
Yes, exactly. With a dural tail. Yes,
dural
and you
tail.
see,
Yes, dural tail.
this is the dura enhancing, and this is also a vessel, so it is with gadolinium. This is a homogeneous enhancement with a dural tail, so it is a meningioma.
Meningioma. Yes.
Okay.
Thank you.
This case, a 49-year-old woman presented with a progressive loss of vision in both eyes. She was otherwise well, and her only medication was hormone replacement therapy. Examination showed bitemporal lower quadranotopia. Investigation: serum osmolarity is normal, urine osmolarity is low normal, serum cortisol normal, FSH and LH low. Prolactin is elevated, thyroid stimulating hormone normal, free T4 low normal or normal. MRI scan showed this lesion. This is a pre-contrast. This is a pre-contrast, and this is a post-contrast. Okay, and this is a cystic component here.
Cystic and solid component, craniopharyngioma.
Yes, this is a craniopharyngioma. Okay.
Craniopharyngioma usually.
Yes,
cystic and solid. Cystic and
yes,
solid component.
Cystic and solid component.
and maybe present in the young and another predominance in this age.
50s to 60s, yes, exactly. This is my last slide. Thank you very much for listening.
Thanks, Dr. Ibrahim.
جزاك الله خير. Thank you.
أهلا You are welcome. You are welcome.
ما شاء الله ممتاز والله. الله يجزيك خير يا رب.
Very illustrative and very helpful for everyone. And I think the real exam, the question like this, just MRI and the scenario, and you can pick the diagnosis from the scenario and in some cases from the MRI, and you need MRI and the scenario to solve the problem. And of course, I must hint about a real exam, either SC and or endocrine or European board, about 20 images, either MRI or CT, either pituitary or adrenal, or nuclear imaging, or bone, or just a skin lesion. So a lot of images in a real exam. So you must try to solve a lot of questions from this bank and from another sources. And I must hint about the most one who benefits from this interactive discussion, who participate in the discussion. So I want everyone to participate in this interactive discussion to increase our interactivity of this presentation. If anyone want any question about this discussion, or want any other request from our bank, I want hint to the next Friday, inshallah, we will discuss hypopituitarism, and we will discuss the very important guideline published by Endocrine Society in 2016 about hormonal replacement therapy in hypopituitarism in adults. This is very important because it is a recent guideline, and it is very helpful in clinical practice and also in the exam. Thanks for everyone. If anyone want to comment, welcome. And I would want to ask, is it Dr. Omar or another Amr? One of participants is Amr. Who is Amr?
He's not listening, I guess.
Okay. Thanks for everyone. If anyone want to do a comment or want any request, welcome. شكرا.
Thank you. شكرا.
Thank you. Thank you.
على خير إن شاء الله. In the next Friday إن شاء الله.
شكرا. الله يجزيك خير.
السلام عليكم.
جزاكم الله خير.
If anyone want to do a presentation, of course it is welcome. If anyone want to do a presentation or PowerPoint presentation in our schedule. Okay. Dr. Ibrahim, inshallah. Naam?
This lecture is recorded. Can I see it later for
ان شاء الله بمشيئة الله. انا بعملهم ابلود بعد ان شاء الله شويه كده اعملهم ابلود ان شاء الله. دكتور ابراهيم كده او كده هيجهز كوشنج، انا ان شاء الله اجهز الهايبوبيتيتاريزم المره الجايه. برضو لو في حد عايز يجهز حاجه اني توبيك اوكي، طبعا كلنا رايحين نستفيد. يلا نشوفكم على خير والسلام عليكم ورحمه الله وبركاته.
وعليكم السلام ورحمه الله وبركاته.